Coronary artery visualization. I discussed how to visualize coronary arteries in the previous YouTube video. I told you how to optimize your equipment, where all to look for the coronary arteries and which segments of coronary artery can be seen on echocardiography with ease, and you should focus on that, and also the clinical utility of visualizing the coronary arteries in my part 1 of this continued talk. So in part 2 I am going to show you the case reports which we have seen past. Yes, it's a good idea that you subscribe the channel. If you subscribe the channel, you will be notified immediately when I put the next video, and that would be an advantage. Now the cases, first I start with the atherosclerotic coronary artery disease. Prior to showing you disease, let me show you a normal variant. In the normal thing, what you see, the coronary artery tends to arise somewhere here. This right coronary artery is arising quite at the distal aspect of the sinus of Valsalva. This is the right coronary sinus of Valsalva. If an aorta from the right coronary is arising, and this is arising quite high up, so this is a high take of the right coronary artery. And once you see this on a short axis view at the aortic valve level with the pulmonary valve here, you see the left coronary artery, but the right coronary artery isn't seen originating here. It is originating little higher up. That's just a diagram to show you on the song. This is not the same patient. The right coronary high take-up, and you guys know, once you are planning to do a coronary angio, and you might need different hardware to hook this artery which is high take-off right coronary artery. Circumflex artery, which I showed in my previous talk, you have, this is the left ventricular section. You see the lateral and anterior segments are not moving adequately. You see the lateral segments here is not moving, and these segments are not moving perfectly well. This is a kind of akinetic, while the septal segments are moving fine. So we do understand there is this area is represented by a circumflex disease, and once we do visualize the coronary arteries, we see that there is the circumflex is the left dominant circulation patient, where we had a calcification of the coronary artery and leading on to the stenosis of the coronary artery here, there is an increased aliasing. Normal coronary artery flow, which I told in the previous talk, is that systolic is lower, the diastolic is more, and the ratio is very important. But in this patient where we did that, you look at the systolic is higher, and the velocity, this is the mean velocity, this is without angle correction. So at the Nyquist limit is 76, and here you see the mean velocity, peak velocity is about 130. Without the angle correction, it would be higher than that. And then this is the diastolic, which is lower, and in fact in the disease segment you can see a separate D and A, which represent E and A of the left ventricular inflow. Now LAD stenosis, you can see in this patient there is an irregularity. This is again the parasternal short axis view at the aortic level, which is slightly angled up. You don't see the aortic valve because this is angled or tilted the probe little cranially, and here you see irregular coronary artery, the left coronary artery, that's the left main, and at the origin of the left coronary artery LAD, you see anterior descending, you see this is a lasing here, a bit of dilatation, and then a narrowing in this pattern. But what you see in the distal coronary artery, you see the left coronary artery flows are antegrade, which indicates that there's no total obstruction causing antegrade retrograde flow. So this indicates a severe proximal stenosis of the left anterior descending artery. And if you see the coronary flows, the velocities in diastole are crossing 160. It's going up to 200 centimeter per second, which is a high velocity. More than 100 or 120 velocity is considered to be abnormal and indicative of stenosis. But in the distal coronary artery flow here is markedly reduced, and there is equalization of systolic and diastolic flows, which indicates again and confirms a proximal LAD involvement. That was a patient who is a 74 years hypertensive, had a CKD, the CRAT was about 4, and the dyspnea for last about 3 months, which obviously we know the reason that dyspnea was because of the ejection fraction, which was about 23% in this patient. And you see there is a global hypokinesia, the LA is enlarged, and then you have a mild pericardial effusion. And a short axis view also, you hardly see any contraction. The ejection fraction was close to 20% in this patient, and there is a mild pericardial effusion present in the posterior aspect. But once we looked at the coronary artery, which as a habit we do it in majority of the patients, do you see the dilatation of the left coronary artery here? The left coronary artery is dilated. Again, orient you, this is the aorta at the level of a little higher than the aortic valve, RVOT, and you see a mild pulmonary regurgitation. But the main focus here is the left coronary artery, right from left main and left anterior descending in the proximal part is dilated. But you see the distal branches of the LAD, the OMs are very thinned out. And if you see here, there is a posterior descending artery which again shows some aliasing and is a thinned out, indicating there is the posterior descending artery stenosis also. Then you see the left circumflex artery, which again has an increased flow and some aliasing here, indicating an obstruction. This gentleman had a triple vessel disease and on a coronary angio, and that showed only the proximal LAD ectatic. Rest of the arteries were markedly narrowed and nothing could be done, was kept on a conservative therapy. Here you see possibly there is an obstruction of the distal LAD, and that's the collateral which you see from circumflex going into LAD. So this was probably a total occlusion of LAD causing these collaterals from the other arteries. So you can get lot of information provided you keep your level and scale up when you are looking at an echocardiogram. You want to see as much as this is a pure simple bonus. The information what you get in any patient, this is a kind of a gift what you get and the free thing what you get. Otherwise you could have finished performing echocardiography in the routine manner. Let me show you a case of ALCAPA which I showed in my one of the YouTube videos. Now in this patient what happens, the left coronary artery arises from the pulmonary artery, and in fact it doesn't get the blood from pulmonary artery to supply the left ventricle, but it forms a shunt because of the pressure more on the right aorta, and then you have a lesser pressure in the pulmonary artery, so there's more pressure in RCA, right coronary artery. The collaterals develop in between left and right coronary arteries, and then the blood from the aorta to the right coronary artery collaterals and the left coronary artery goes to the pulmonary artery, and depending upon the size of the collaterals there is it could be a small or a large left to right shunt. So then these patients usually tend to have dyspnea on exertion, have angina on exertion. X-ray can show a varied degree of cardiomegaly depending upon the ischemia and LA-LV dilatation, but it could also be there because of increased shunt, left to right shunt. You can have shunts because this is a post tricuspid valve shunt. Shunts are going to be large and can have a plethora in the lungs and can have a dilated pulmonary artery, but ECG typically gives you an impression of a poor progression of an R wave and anterior wall infarction pattern. And this is a rare entity. Majority of the patients do not survive first year of their life because of markedly increased ischemia, more than 2:1 left to right shunt causing heart failure. So that's a combination of ischemia and heart failure in ALCAPA. I'm going to show you an adult with ALCAPA, which is uncommon because many of them don't survive. In here, let us see each and every aspect of this echo. You see the right ventricle, normal size, contracting normally. So is the right atrium. The septum is bulging to the left side. That means the LA pressures are higher, and in the LA pressure you see the dilatation of left atrium, you see the dilated enlarged left atrial appendage. Also here you see the mitral valve is not opening too well because of the reduced ejection fraction, the global hypokinesia with more hypokinesia or severe hypokinesia involving apical segments. You see this false tendon in the left ventricle. You notice, and let me show you in the next video a little more carefully here. What you see is that you see in this video, you see the papillary muscle is scarred, calcified. Okay, so this actually indicates global endocardial ischemia, and then your eyes are drawn to another area which is right AV groove, where there is a right coronary artery which is going on the left AV groove. You see the left circumflex. Normally here you don't see it. You see a large circular structure which is the right coronary artery, and confirmed on a color Doppler you see the aliasing there. So now his situation up till here is that dilated LV with little more hypokinesia of the apex. You have a scarring of the papillary muscle with the calcification, and immediate then you have a right coronary artery dilated. I think there's hardly any differential you have. This is a patient of ALCAPA. Here you see the mid posterior segment is slightly more hypokinetic, the EPSS is less, and this is an ejection fraction which is about 33%, and you see the calcification in the endomyocardium, and that the reason is that global ischemia of the entire myocardium. This calcification and fibrosis is again very peculiar for ALCAPA rather than other atherosclerotic coronary artery diseases. Now here you see the aorta, the right coronary artery origin, which is obviously, this is about 5 millimeter, which is considered dilated, and then you have a prominent sparkling coronary arteries around in the circumflex territory, and you know something is going wrong here. And when you do a two-chamber view, you see the posterior descending artery, the PDA is markedly increased flow because there is a right coronary artery and a PDA, and then this PDA would form lot of collaterals here with the joint hands with the left coronary circulation, and by forming collaterals there this blood flow would through the collaterals go into the left coronary artery and into the pulmonary artery. Here you see the ALCAPA, you see the left coronary artery arising from or connected to pulmonary artery, and I just say connected because the blood flow is from the left coronary artery back into the pulmonary artery because of the pressure gradient, and you see a forward flow in the pulmonary artery, which many a times you see in patent ductus arteriosus. It's a good way to CT angio gives you a lot of anatomical markers for a coronary artery anatomy, and occasionally you might have to resort to coronary angiogram, where in this case what you see is that the right coronary artery markedly dilated, collaterals filling the left coronary artery, the blood is actually draining into pulmonary artery. You see the main pulmonary artery, and then you have the branches of pulmonary artery here, the right one, the left one. Okay, this was a very unusual case of ALCAPA in the fetal circulation. You notice here the black arrows show you a blood flow in the coronary artery. Let me tell you, this is not an artifact because of the pericardial fluid. You see the pericardial fluid little outside this structure. So this is a coronary artery which is prominent. So you know, if the coronary artery is visualized in fetus, that means this is abnormal. You see a long length of coronary artery, a prominent coronary artery on the right side, which indicates the right coronary artery. And why the right coronary artery is prominent? The reason is the left coronary artery opens into the pulmonary artery. That's the right coronary artery opening into the pulmonary artery. And remember, when we saw in the adult patient, where we saw the blood flow from the left coronary artery into the pulmonary artery because of the increased pressure in the fetal circulation, the PA and aorta pressures are same. That's why you see a bidirectional flow in the left coronary artery. Again, in the zoomed view, you can see where the yellow arrows are the coronary artery flow, which is to and fro and opens into the lateral aspect of the pulmonary artery. Surgically, many times it's difficult to mobilize the coronary arteries, and they are dilated coronary arteries and fixed to the myocardium and difficult to mobilize, and many other techniques like intrapulmonary tunnels like Takeuchi's procedure. But remember, this is now been used because there could be an obstruction or problem in the pulmonary artery. Other way is to ligate pulmonary artery and put a lima graft on that. Next cases which I am going to show you are coronary cameral fistulas to the LA, to RA, to RV, to LV. I have a case of fistula to LA and also into the RV, so I'm going to show you. I would show you coronary fistula into pulmonary artery, which you guys many a time see when you do a coronary angiogram. There is a sizable number, and that's not a rarity. You see few of the particularly the right coronary artery or circumflex artery, sinus node arteries tend to form a fistula into the pulmonary artery. I would show you one case of coronary artery fistula entering into the pulmonary vein. So that's a patient which gentleman, now this had a LV, LA, the aorta, LV functions, LA size are all fine, RV, OT is contracting well in a normal size. But what you see here is a dilated coronary artery. At the first we thought this is the right coronary artery. Honestly, we reported this as a dilated right coronary artery creating a fistula, but on an angiogram, I would show you that angio, it was the left coronary artery. So where did we mess up? On retrospectively reviewing the case, we saw that the flow is not coming from here, it's coming somewhere else. I show you on the next slide. All right, now you see this is the left coronary artery which is coming from this side and going down. So it was the left coronary artery which was kind of coming and looping around the right coronary artery, looking as if the right coronary artery is dilated. Now see this videos, you in the sequence, the first is an LAD which dips down posteriorly, and then this dips down to enter into a chamber in the posterior aspect of the right atrium, and this chamber, if you see, this is the flow. The first starting is LAD going posteriorly, follow this LAD. We actually follow the coronary artery or a fistula till we see the entry point. So that's an entry point into a kind of an aneurysm, and then this aneurysm is a restriction and opening into the right atrium. Because of this restriction here in the entry point of the coronary fistula, there is a dilatation of this aneurysm formation in the right atrium, and that's where you saw this fistula, and this is entering into the right atrium, and it's having a continuous flow because of the obstruction here. So looking at the coronary artery, I told you this was the left coronary artery. The left coronary artery is markedly dilated, and you see this fistulous kind of a structure here, and you see the flow entering into the right atrium in the continuous manner. The plan was to coil embolize this in 2 stages. Now again the next case, this is left atrium, left ventricle. What you see here is the ejection fraction is borderline. It was about 40% on visual inspection here, but I would show you it was less in the further slides. Now this is the bilateral regurgitations, the tricuspid one, the severe and a moderate mitral regurgitation. You see RV also is dilated, it's not contracting well, but this red flow is an antegrade flow. To our surprise, in one of the angled views, we didn't see this antegrade red color flow. We saw a retrograde flow going in this direction, that is blue, and where this blood is coming from. So now our search went on, and we saw this is angulation of the left parasternal long axis view. On angulating, you see this artery, this artery, the left anterior descending, which is coming out of the aorta, is markedly dilated going through the interventricular septum, right? Incidentally, you see the cross section of the pulmonary artery valve, and you see the pulmonary valve is dry leaflet. Just pure coincidental visualization I thought I would share with you. Another view of the aorta giving rise to the left main and LAD, which is going through the interventricular groove. All right, so this is the origin of, now you see the left main, you see the left coronary artery. Here the circumflex is not seen, which is not dilated. It is the LAD and the left main which are dilated. This is the cross section view at the aortic valve level. Right ventricle, tricuspid valve, right atrium, left atrium, and then this is the origin of the left main and the left coronary artery on the distal part. See the flow, the markedly increased flow. Again, that short axis view where you see the right main artery dilated, the LAD which is going ahead, and you see this further next step. You follow the fistula, and if you follow the fistula, you follow the anterior descending artery on the interventricular groove between the right ventricle and left ventricle anteriorly, and you see it is turning close to the apex. It's opening into the right ventricle, and the next way what you see is that the coronary artery fistula with a wide mouth, no obstruction to the flow, is entering into the right ventricle. So this was a patient with the very large left coronary to the right ventricular cameral fistula. We saw a similar kind of thing in the gestation of 23 weeks. Again, remind you that size of the heart is about an almond. Let me orient you here. That's the spine of the baby, and these are the vertebra, and that's the descending aorta, the arch of aorta, and the ascending aorta. That is an inferior vena cava in the same sagittal plane. This is the right atrium in the sagittal plane. This is how you recognize the anatomy. And once you see there is a to and fro flow in the arch of aorta, which actually indicates that there is some runoff in the ascending aorta. The commonest reason of runoff here, you could always think, would be aortic regurgitation. So when you see here, you see the pulmonary artery, and that's the aorta, and this is the aortic valve. There is a to and fro blood flow in the aorta up to the aortic valve, and no regurgitation into the ventricle. So what's happening? Where is the blood leaking or going from the aorta? And this is where it was going. You see this is a right coronary artery, a dilated channel which is arising from the aorta, and then you see there is a blood flow from the aorta which is antegrade. This is the direction, that's why it's red, and you see this is regurgitating into this channel, which probably is the right coronary artery, and then you see this is opening into the artery is opening into the right ventricle, and if I can show you, this is where it is opening and draining. And again I'm going to show you, stop here, and then this is what I showed. This is the right ventricle. So this was a patient of a right coronary artery cameral RV cameral fistula, or we have a similar kind of case reports in the literature, which is aorto RV tunnel. So another coronary a fistula in the fetal circulation. This is 24 weeks gestation. You see this is left side, left atrium, left ventricle, right atrium, and there's a right ventricle and right atrium. That's the descending aorta, and this is where the aorta would have been, and then this is an artery which is the left circumflex artery. That's the artery which goes toward the right side. This is most likely a sinus node branch of the right circulation. Now this artery from the circumflex, then you see this circumflex artery which is markedly dilated and entering into the right atrium through this fistula. This is the kind of similar case, an aneurysmal dilatation of this fistula because of the obstruction at the drainage site of the coronary AV fistula. Now this fistula is similar what I showed you, but this one is in the right atrium. What we showed you was LAD into the right atrium initially. Another patient of a coronary to pulmonary venous fistula, very few case reports been reported, and you are witnessing one of them. And this is a patient who had other reasons for RARV, dilated, hypertrophy, there was coarctation. And this patient, now you see, as the right ventricle is markedly dilated, and what we found, the LV also is hypokinetic with the moderate to severe mitral regurgitation. You see some flows of the coronary around here. The coronary artery abnormality was coincidental in this patient, and you see the right aorta. This is the cross sectional view, and this is angled one. That's the RVOT which we see, and the tissue over the RVOT. You see this is the left coronary artery. This there is a looping back. You see this blue color, and this is the fistula, coronary fistula, which loops back, again goes into this this coronary artery, travels like this to enter into the pulmonary vein here, which enters into the left atrium. Sounds complex, but let me give you a step by step. So first step, aorta, now the coronary artery. So that's the left coronary artery, LAD, and then the next step is, you see this is a kind of a looping down of the fistula. The coronary artery, dilated coronary artery, actually goes in a kind of a loop, and then to enter into this pulmonary vein, and this pulmonary vein eventually enters into the left atrium. So that's how the flow looks like. Aorta to LAD, LAD to this tortuous vein because of the fistula, which enters into the pulmonary vein and the left atrium. I am going to show you, which is pretty common, you guys must have seen it, doing an angiogram. Once you do an echo, you see this small spurt of blood here entering into the pulmonary artery from the lateral side, and that's what that is. This is the flow what you see in the coronary artery, a zoomed view, and optimizing the image by the color Doppler, smoothing the color, and you see this coronary artery which actually opens into the pulmonary artery. So guys, this was a part of an adult and pediatric circulation, and I saw coronaries in the fetus also. I would show you more, but good idea. If you like my channel, subscribe it so that you would be notified as and when I put any video which you like. Thanks for watching this. Good learning and happy learning.